Hi guys, welcome back. I hope you've had a great week. How are you doing? How is your USMLE step 1, step 2 CK preparation going? All right, the last time we looked at abdominal pain, ascites, and hepatomegaly, we talked about Budd-Chiari syndrome. We saw how Budd-Chiari syndrome tied into hematology, how it tied into biochemistry. We talked about Vacav's triad, endothelial injury, stasis, and hypercoagulability. I hope you still remember all of those things. Do you still remember the appearance? What we describe the appearance of the liver in patients with right heart failure or Budd-Chiari syndrome to be? You remember nutmeg, appearance of the liver. We talked about polycythemia vera and JAK2 gene mutation. I reminded you that polycythemia vera is a stem cell defect and paroxysmal nocturnal hemoglobinuria is also a stem cell defect. We talked about phlebotomy for treating polycythemia vera and hydroxyurea. We talked about the mechanism of action of hydroxyurea, which is inhibition of ribonucleotide reductase, and then we talked about other enzymes in the pyrimidine synthesis pathway, like thymidylate synthase. And we talked about medications that inhibited thymidylate synthase, 5-fluorouracil, and then we talked about medications that inhibit B9, that is folic acid, folate, that plays a role in that pyrimidine synthesis pathway, methotrexate, trimethoprim, pyrimethamine. We talked about all of those things. Today, we are going to go into a different rapid review headline: abdominal pain, diarrhea, and leukocytosis following recent antibiotics use. This one should be very easy. A lot of students get this right the first time I ask them. Abdominal pain, diarrhea, and leukocytosis following recent antibiotics use. It jumps out to a lot of students immediately. This is put up, and that would be what? Pseudomembranous colitis. Pseudomembranous colitis. Do you remember the organism that causes pseudomembranous colitis? I hope you said Clostridium perfringens. Then you're going to be asking yourself, how does Clostridium perfringens cause, sorry, did I say Clostridium perfringens? Clostridium difficile. Oh my goodness. My brain is not working these days. I'm getting old. That would be Clostridium difficile. How does Clostridium difficile cause pseudomembranous colitis? How does Clostridium difficile cause disease? Then you'd be reminding yourself it has a toxin A and a toxin B. You remember that. And together, these toxins are going to produce watery diarrhea. And they're also going to destroy the cells of the intestines. That is your enterocytes. They're going to cause enteropathology, or basically just destroy the enterocytes. That's it. And that is what produces pseudomembranous colitis. That's about as much information as they want you to know about the pathophysiology of this disease. It's a little more elaborate than that, but nobody really cares for all those details. And then, why do people get Clostridium difficile infection? One of the things you want to realize is all the organisms in the GI work together to create a balanced ecosystem within the gut. Now, when people take medications like what? Clindamycin, ampicillin, which are broad spectrum sort of antibiotics. Of course, you have other medications, fluoroquinolones, proton pump inhibitors, and so on and so forth. You do away with the gut bacteria. You create an imbalance in the gut, decrease gut bacteria. Most bacteria will be wiped out by these antibiotics, but Clostridium difficile will not. In fact, because you've wiped out all these other bacteria, now Clostridium difficile has enough room to grow, and it begins to grow and develop. Classic question in your vignette: they'll give you a patient. They may give you a patient that's hospitalized, or maybe not hospitalized, but the patient will be put on some form of broad spectrum antibiotics. And that is important, right? Broad spectrum antibiotics. If the patient is on broad spectrum antibiotics, 2 days later or thereabouts, 3 days later, they will develop diarrhea. They will develop diarrhea, watery diarrhea. How do you diagnose Clostridium difficile? You're going to be looking for the toxin in the stool. And if you're looking for the toxin in the stool, you're going to be using PCR. Do you remember that? And then there are complications that occur with Clostridium difficile infection, right? They don't typically ask you for the complications, But Clostridium difficile can cause toxic megacolon. You may want to remember that. Clostridium difficile can cause toxic megacolon. It's not common on your exam that are going to ask you that, or even result in septic shock. But those are not common on your exam. These information I've written down here are what they're likely to ask you about. How are you going to treat patients with Clostridium difficile? You're going to be thinking to yourself, oral vancomycin and fidaxomicin. At this point, you should want to ask yourself, what's the mechanism of action of oral vancomycin? Do you remember that vancomycin is a diala-diala analog and inhibits cell wall? Do you remember that? What's the side effect of vancomycin? Do you remember the NOT? Nephrotoxicity, ototoxicity, thrombophlebitis. If you're thinking nephrotoxicity, ototoxicity, and thrombophlebitis, okay, let me probably write it out, I guess. Let's see. Okay, so if you are thinking vancomycin is going to cause nephrotoxicity, ototoxicity, and thrombophlebitis, then you're going to be asking yourself, do you remember any other medication that causes similar side effect, that also causes nephrotoxicity, ototoxicity, and thrombophlebitis? Do you remember any such? Well, not thrombophlebitis, but a medication that causes side effects that look close to what vancomycin does. And I hope you're thinking of aminoglycosides. Aminoglycosides. Do you remember the side effects of aminoglycoside? They also cause nephrotoxicity. They cause neuromuscular blockade. They cause ototoxicity. And they cause teratogenicity. That teratogenic. Somehow it adds up to not, for me, I always try to tie it together with vancomycin. It helps most of my students remember those two medications side by side. You can go on and ask yourself the mechanism of action of aminoglycoside, and you can keep going what medications are in that class that we call aminoglycosides. Now, one of the things you want to know is every time you see a medication, you have to ask, what is the mechanism of action of this medication? What is the side effect of this medication? And what is the mode of resistance against this medication, especially if it's an antibiotic? These are questions you ask every single time you think of a drug. It helps you review that drug, because a lot of students have problems with pharmacology. So pharmacology is so difficult, but pharmacology can become the easiest thing. Why? Because the mechanism of action is always the mechanism of action. The side effect is always the side effect. The toxicity of a drug, the mode of resistance of a medication will not change, at least for a few years to come. So when you think of a drug, you're going to have to ask yourself immediately at every juncture, what is the mechanism of action of this medication? What is the side effect of this medication? And if it's an antibiotic medication, you're going to be asking what's the mode of resistance against this medication. And in the case of vancomycin, if you remember the mechanism of action, and if you remember that vancomycin is a diala-diala analog, then you would remember that the mode of resistance against vancomycin was simple for the bacteria to change diala-diala to diala-dilac. That was the question of one of the MBMs I wrote some years back. So you should remember that. Changing diala-diala to diala-dilac. If you've answered this question and you've gone through this, you've actually reviewed everything pseudomembranous colitis and everything about Clostridium difficile that you really need to know. The next thing you're going to be asking yourself is, okay, what else can I think about around this topic? Can you think of any other condition where if people take an antibiotic, you can wipe out the normal flora of a part of the body, and that can lead to infection? For example, if you give women broad spectrum antibiotics, for example, or if women do some of these vaginal therapies that they do, they can wipe out the microbiodata of their vagina, and that can actually lead to what? Infections. Do you remember associations like this? So things that happen in one part of the body, for example, can also happen in other parts of the body. You have to remember that these diseases or these conditions share a common mechanism. That's where you reduce the number of things you are going to be having to memorize. There are a number of conditions. I was asking a student the other day, I said, if I give you someone with Raynaud phenomenon, for example, I give you someone with esophageal spasm, and I give you someone with Prince metal angina. I don't know, is it metal, mental? I don't know. Prince metal angina. Do you see any relationship between these three things? Do you see any relationship between these three things? They all involve vasospasm. Vasospasm, esophageal spasm, they share similar mechanism. And if you think carefully, you would realize that they are all treated with calcium channel blockers. Now, easy, right? You don't have to memorize, oh, renal phenomena, we use calcium channel blockers. Esophageal spasm, we use calcium channel blockers. Premetal angina, we use calcium channel blockers. Why do we use calcium channel blocker in them, all in three of these diseases alike? Well, is it perhaps because they share similar mechanism? Is it perhaps because they share similar mechanism? So this is how you want to be looking at this. This is how you want to approach these diseases. And this is how I would say that you think of it. While you're thinking of Clostridium difficile, you may want to remind yourself of other types of Clostridium. You may want to remind yourself of Clostridium perfringens, Clostridium tetani, or tetanus, or tetany. Whatever that is, Clostridium tetani, Clostridium perfringens, Clostridium botulinum. You remember Clostridium botulinum was what caused botulinum toxin, or what produced botulinum toxin, for example. Do you remember what botulinum toxin did? Botulinum toxin caused floppy baby syndrome in the child that the mother decided to give honey. That's in children. In adults, it's going to cause muscle weakness. Do you remember a disease that causes something that looks like floppy baby syndrome? A neurological disease, a disease in neuro that causes something that looks like floppy baby syndrome. I'll give you some ideas. It is as a result of a mutation is in SMN1 gene. It's as a result of a mutation in SMN1 gene. Do you remember that disease? I'll give you another clue. It's as a result of damage to Renshaw cells that produce glycine. These babies are going to be floppy from birth. Do you remember that disease? Do you remember that disease? Okay, one more clue. It is autosomal recessive. These are points that have been asked on the exam about this disease, right? These are questions I have seen on this concept on your exam. A disease in neuro that causes the baby to be floppy, associated with SMN1 gene mutation, damage to Renshaw cells, it's not tetanus, glycine producing cells, which are the Renshaw cells, and it's autosomal recessive. Do you remember what that disease is? If you remember, put it in the comment section and let me know. Then we talk about tetanus. For example, when you think of Clostridium tetani, do you remember the neurons that are involved in tetanus? Do you remember the GABA neurotransmitter? Do you remember that glycine? Again, glycine here, glycine here. Do you remember that glycine also is a neurotransmitter that is affected or decreased in people with tetanus? Do you remember that, again, Renshaw cells are involved in the pathophysiology of Clostridium tetani? Do you remember how the tetanus toxin gets into the spinal cord? Do you remember retrograde transport in the axons? Do you remember that? Do you remember any other condition that is probably going to affect the patient via retrograde transport? Do you remember herpes? When people have primary herpes infection, the first time they get the infection, do you remember that it's retrograde transport? Do you remember that herpes reactivation is going to be what? Anterograde transport. You sit down, again, this is rapid review. You sit down and you think to yourself, you sit down and you ask yourself, where are the connections between these organ systems? How does, just reflect on what you study. Once again, it is not how long you sit studying that makes you remember information for the long term. In fact, I would argue that the longer hours students study and reread and reread and reread, the worse their performance. If you want to begin to recall information, put away the books, sit down with a blank page like I'm doing now, and begin to think. Begin to reflect on what you've studied. Recall the whole of an organ system if you can. Just sit down and talk to yourself, think out loud. And this is one of the things I'm going to also highlight in the test taking mastery videos that I'm going to be making. If you've not signed up for the test taking mastery already, this is the time to get a reminder. Click the link down below, sign up for that. You're going to learn exactly what you need for your USMLE. How to answer questions effectively and fast. How to study and how to approach USMLE questions. And I will stop there. I don't want to make this video long like the last one. I will see you guys in the next one.